Hello, I'm going to talk to you today about diffuse liver disease, some of the pitfalls that you might encounter, and some of the hints as well. I'm not going to cover a lot of the basic information because you already know that. I'm from California, and so the obligatory surfing slide is here. First, talk about acute hepatitis, and generally we're talking about hepatitis A here. Acute hepatitis is really a clinical diagnosis, and we don't really require imaging to make the diagnosis. The labs, however, can be confusing, and we can have elevated or normal labs, which will prompt clinical confusion and therefore an ultrasound examination. The first thing I'd like to talk to you about is what I call the myth of the starry sky in acute hepatitis. Many people believe that increased periportal echoes coupled with decreased parenchymal echogenicity is virtually diagnostic for acute hepatitis, and this in fact is not true. The findings with respect to the periportal echoes are related to normal anatomic variability because of the variations in the amount of periportal fat, not related to the hepatitis. And in fact, this has been shown to be true in a blinded study that was done in Italy some time ago, where they did a study of 791 patients, and only 19 of the patients with acute hepatitis had this pattern. And in a control group comparing normals and patients with hepatitis, there was no difference whatsoever in the frequency of this finding. So the starry sky is not something that you ought to pay attention to. Here's an example of the starry sky. Of course, there is such a thing as the starry sky, as we see in this Vincent van Gogh painting. There is one little hint that can be useful to you, however, in acute hepatitis, in that often these patients will have a very edematous, thickened gallbladder wall. Some people call this a striated gallbladder wall, and this can actually suggest the diagnosis of acute hepatitis. In fact, this is usually or often the only ultrasound abnormality in acute hepatitis. Here's an example of hepatitis A, and I'll use the mouse as a pointer. And you can see that here we have the submucosa, and this is a massively thickened wall with a small lumen. And this is a hepatitis A patient. Here's another hepatitis A patient whose gallbladder essentially has no lumen. It's totally obliterated because of the wall thickening. One thing that is also useful is if you have significant gallbladder wall thickening with a very small gallbladder lumen, less than 15 millimeters, this should suggest a non-intrinsic cause of gallbladder wall thickening, that is to say, an abnormality not related to gallbladder disease itself. There are other things, of course, that cause gallbladder wall thickening. Here's an example of a cirrhotic patient who has a low albumin and portal hypertension, and we see the ascites and the thickened gallbladder wall, both of which are caused by the cirrhosis. Here's another patient who has cardiac disease and a thickened gallbladder wall with a very small lumen. Here's a less usual cause of gallbladder wall thickening, and that's infectious mononucleosis. And there are other things that can do this too. Of course, this small lumen rule doesn't always work. Here's a patient who has a lumen that's larger than 1.5 centimeters and a thick wall, and this is a patient who's cirrhotic and has portal hypertension and a low serum albumin. Here's a patient who actually has acute cholecystitis that looks sort of like the cases that I've already shown you. This patient happens to have a small gallbladder wall lumen and a thick wall. So the rules are not perfect. Here's the same patient who has cystic duct stone in this particular video clip. So the rules are not perfect, but they work reasonably well. So we do have fires in Los Angeles, and I just put this in as an example of that. All right, let's talk about fatty liver. Fatty liver is becoming an increasingly recognized health issue, especially in the United States, and elsewhere too, of course. It's a common condition and has many different causes. The actual pathway to fatty liver is poorly understood, but there are many conditions that are associated with it. I've listed some of them here: alcohol, diabetes, obesity, malnutrition, drugs, and many others. One concern is the so-called non-alcoholic fatty liver disease, or NAFLD. And in the US, this is the hot diagnosis in hepatology. You can get progression from fatty liver to what's called NASH, which is steatohepatitis, where you have actual liver inflammation with a fatty liver, and then NASH with fibrosis, which can lead to cirrhosis. And in fact, fatty liver disease is probably going to be one of the major causes of cirrhosis in the United States. And here's an algorithm that I'll leave up for a moment or two for those of you who want to look at this. Hopefully you can review it. And there's a reference from where this came, talking about the progression of fatty liver disease and natural history of non-alcoholic fatty liver disease. Now, there's no problem making the diagnosis of severe fatty liver disease. Basically, this is the classic situation where you have markedly increased liver echogenicity and visible attenuation of the sound. This is only seen, however, in a minority of the most severe cases. In this circumstance, the diaphragm is poorly seen and the vessels in the liver are indistinct. Here's an example of such a case where there's obvious severe attenuation. We can barely see the diaphragm. But this is the severe case, which is not really terribly difficult to diagnose. It's more important to make the diagnosis of mild fatty liver because we want to catch the fatty liver disease early so that perhaps something can be done to mitigate the potential complications of the illness. The way that we make this diagnosis, there are several actually, but one is to compare the spleen and the liver, not so much directly, but using the kidney as an internal standard, and I'll show you what I mean by this. Normally the spleen is more echogenic than the liver, but ordinarily you can't compare them directly. Now, here's a circumstance. This is an anatomic variant where the left lobe of the liver overlaps the spleen here. And in this particular circumstance, you can compare them directly, and it allows us to see the echogenicity patterns. So this is a long axis scan in the left upper quadrant. And here's this liver overlapping the spleen. And notice how the liver, this normal liver, is more echogenic than the spleen. And of course, both are more echogenic than the renal cortex. So that's the normal situation. Now here's another patient with a similar anatomic variant with the liver overlapping the spleen, but in this circumstance, the liver is more echogenic than the spleen. So this is fatty liver. It would be nice if we could directly compare the spleen and the liver in all patients, but it's only possible in a minority. Therefore, we have to use the kidney to help us. Basically, what we do is to compare the liver and the spleen to the kidneys. And if the liver to right kidney echogenicity is greater, than the difference is greater than the echogenicity of the spleen compared to the left kidney, fatty liver is present. So if the liver looks more relatively echogenic to the kidney than does the spleen, that's abnormal. And here's one such example. On the right, we see that there is a fairly pronounced difference in echogenicity between the liver and the right kidney. On the left, however, the spleen is not nearly so different from the renal cortical echogenicity. So this is diagnostic of fatty liver and is an aid to making the diagnosis in more subtle cases. Another important thing to look at is fatty sparing, or for that matter, focal fat. These entities can be diagnostic of fatty liver, and they can also create problems by simulating a mass. And one needs to be aware of both of these features. Here's an example of a patient who has very prominent sparing in this otherwise fatty liver. And this is often confused for a mass. And you don't really want to go ahead and do additional imaging that isn't necessary when you have a finding that it's actually typical. It's just a question of learning how to recognize what's typical and what's not. Here's a typical area of increased echogenicity related to focal fat, which is, of course, a different situation. And this, too, can simulate a mass. So variations locally in fat can simulate masses, and one needs to be a bit careful about that. Here's a combination. Basically, this patient has an area of focal fat and peripheral hypoechogenicity, which is sparing. So this almost looks like a lesion with a halo, but this is, in fact, just fatty, focal fat and sparing around it. Here's another one. This is, I think this is actually the same patient who has this central hypoechoic area and peripheral increased echogenicity.